Hello everyone, how are you all? Thank you so much for joining today's session. So we are going to start our cardiology session tonight. So as you know that this is our first session of the first 2 weeks free sessions. So I hope you guys enjoyed the classes because the classes are designed in a way so that you guys can have an idea of how we take the classes for the next 5 months time. So normally as we are doing the cardiology, which is one of the very important topics for your exam, from cardiology, we will have some clusters. And with the clusters, the important thing is that you can just remember the format of the history for like 3 or 4 cluster from whole cardiology. And just with those format, you can answer any of the questions that can possibly come in the exam. So always try to make a cluster-wise approach because otherwise what will happen that you have to remember a lot of cages. And it's really, really hard because in the exam, if you don't have a format in your mind, it will be really difficult to ask differential diagnosis, finish the cases within the given time. So there's a reason we always do cluster-wise approach. I will show you how the cluster works tonight and you guys will have an idea. And all our sessions, all our classes are based on those clusters. So every subjects like gynecology, obstetrics, pediatrics, psychiatry, everything is cluster-wise approach. Okay, so that's important. Like for your cardiology, what are the possible clusters you should have? One, you should always have a syncope cluster. You should have a palpitation cluster. You should have a chest pain cluster. These three cluster is all that we need. Same like in your respiratory system, we should have a acute shortness of breath cluster, chronic shortness of breath cluster, cough cluster. Okay, so apart from that, nothing much in in respiratory system. So we'll go through all those clusters in our sessions, but tonight our main approach will be cardiac clusters. We will start with the syncope cluster tonight, and then if we get some time, we will move into the palpitation cluster as well. And you will see that how just doing a doing a history format, you can possibly answer 4 or 5 cages. So what happens in that time that you don't need to memorize or you don't need to remember 4 or 5 cages differently. Just by doing one case, you can easily finish 4 or 5 cages. That's the importance of making things precise rather than doing a lot of cages, and when the time comes, you cannot remember the things that you have memorized. So we'll go through all these things. I'm just waiting for others to join. So I think already we are past 7, so past 8. So we can start today. Is everything is fine? Sound is good. Sound should not be very low. It must be in your cages, Dr. Amjad. I take classes like that for for the last 1 year. Sound low should not be low actually. Is it for everyone? Because someone of you might have the Zoom audio settings are low. That's the reason you might hear it as a low, because I'm talking in like really high tone and I can see my microphone is going up. So it should not be very low. Let me have a look. Why? Someone is saying it's okay. Some people are saying low. Why it's like that? Okay, let's start the session, see that if it's low for everyone or not. I'm using headphone. Yeah, if you guys are not using headphone, I think it's a good idea to use a headphone also. Good. So this is start. So we'll start with the cardiology and we'll start with the syncope cluster tonight. And those who are in the Facebook, you guys can hear me well? Voice is good. All right, great. Let's just start. So just let me give you an idea. So when we do some cages, our classes are designed in a way so that we will finish the theory first. And after doing the theory for one or two classes, then we will do some role play on those cages. We do role play mainly on all the cages that's possibly appearing in the exam or somewhat important for your exam. Okay, so for the last 1 year, the cages which are important, we have like for all those cages, we have a file which will be uploaded in the software once you join the sessions or course. And from there, we will take the important cages and we will do role play randomly. So that's how we plan our course. That's how we make sure that if anything missed in our theory session, that should be covered in our role play session so that everything is covered. We usually don't keep anything left so that you guys don't feel upset or you don't feel like this case is new for me when you are at the exam. Now, for a syncope cluster, always when you do a cluster, the first thing that you need to do is to make sure you have a differential diagnosis, a lot of differential diagnosis, so that at least you are able to remember 5 to 10 DD for each of these clusters. Now, what are the differential diagnosis of a syncope? If you divide syncope, differential will be falling under CVS, CNS, and others. For the CVS, we have arrhythmia, aortic stenosis, HOCM, myocardial infarction, and prolonged QT syndrome. For CNS, always for CNS, keep these things in your mind. So it will be either trauma, tumor, infection, injury, and lastly, epilepsy. So trauma, tumor, infection, injury is for always. Okay. So always remember trauma, tumor, infection, TIA or a stroke, and epilepsy. For others, there are a couple of others differential diagnoses, which is also important. One is vasovagal syncope, Pushual, hypoglycemia, anemia. Some of the medication can cause it, and it's very important is medication-induced syncope. Then we have a stress or psychogenic syncope as well. For your exams, for syncope cluster, main important is your aortic stenosis, which is a handbook case. Prolonged QT syndrome is also important, and your medication induced, and there is postural hypertension, there is vasovagal syncope. These 5 cases are more or less important for the exam, but obviously you should ask all the differential questions when you are asking the history. As I understand that most of you has seen that how AMC is changing the pattern of their exam, right? So we have taken an exam just a couple of days ago, and you have seen that how the exam can be done through online. It will be more or less similar like that, but some of the things will be different, which we will know once the exam starts. Okay, but the pattern of the exam, asking questions, that part will be always same. So you have to know all these things that you should know. There will be no changes in the cages that you need to prepare. The cages that used to come or that were important for your exam before, that is also important for now, and it will be important forever. So you have to go through all. Just there will be some changes in the physical examination cases. Otherwise, everything will be similar. So you should not think that, well, I don't know what the questions will be. I don't know what are the cases can be coming. I don't know what will be the new pattern of exam. No, the thing is that important things are always important. You have to always know some things before you appear in exam. So these cages like a cardio cluster, respi clusters, those are always important. Whatever exam you are appearing, you should have a good idea on these cages. So don't think in that way. Now, so for each of these differential diagnosis, we have to ask at least one or two questions to rule out differential diagnosis. Now let's move into the history and then we will go through all those cages. Now for history, if a patient comes to you for any acute cases, like acute abdominal pain, patient had a syncopal attack just 2 hours ago and now presents to you. These are acute cases, right? For any acute cases, make sure that you ask if the patient is vitally stable or not. Before you start asking any history, that's the key step to make sure your patient is hemodynamically stable. So how you approach these sort of cases? Say that always make sure you reassure the patient. Always make sure you greet with the patient. That's very important. Your starting or introduction shows that how good you are. So start like that, like, hi John, this is Dr. X, one of the doctor here. I understand that you lost your consciousness and you had a fall couple of hours ago. I'm really sorry to hear that. How are you feeling now? Are you comfortable at the moment? Yes, doctor, I'm fine. I just don't know what exactly happened. That's why I came. That's really nice that you came here. I really do appreciate that. Please don't worry. As you are here now, we will find out what caused your problem and we will try to manage your symptoms. But before I ask any questions to you, I need to make sure you are stable enough to answer any questions. Is that all right with you? I will just go to my examiner and I will come back to you within a moment. So, dear examiner, I would like to know if my patient vitally stable for further history. Okay, that's how you should start. So, dear examiner, is my patient vitally stable to go for further history? Sometimes examiner will say, what do you want to know? Or examiner will say, please proceed to your task. So if they say, please proceed to your task, so you will start asking question, just maybe the patient is stable, that's why, or maybe examiner doesn't want to give the examination findings now. So whatever it is, if they say that, go to ask the questions. And then if not, sometimes they can ask you, what do you mean? Then you have to ask specifically, doctor, I would like to know the blood pressure and pulse. Now, for syncope cases, in blood pressure, you have to ask blood pressure with a standing and sitting position because that one of your differential diagnosis, postural hypotension. So, standing and sitting BP is important to us. Then, in the pulse rate, because arrhythmia is one of your DD, you have to ask, is it I would like to know the pulse, rate, and rhythm. So rate will be high or low or normal, and rhythm is important to rule out any arrhythmia. Okay, and normally what are the vitals? We ask blood pressure, pulse, temperature, respiratory rate, and oxygen saturation. These five are the vital signs that you ask from the examiner. Clear? Now, after that, once you finish that, then you come back to the patient and say, thank you so much for your waiting, John. Now, I would like to ask you, can you please tell me what exactly happened today? Always start with an open-ended question so that patient can give you the history that he's supposed to give to you. All the AMC role players, they usually has a script that they will provide to you. If you don't ask those open-ended questions, they will be unable to give that particular things that would actually help you to reach a diagnosis. Clear? So that's the reason you have to always ask an open-ended question. So can you please tell me more about what exactly happened? The patient will say, Doctor, I was just doing some exercises in the morning and I just feel lightheaded and I fall. So that exactly what happened. So if the patient doesn't give you what you want to know, then you have to start asking one by one question, closed question. So what exactly were you doing at that time? Is it for the first time or not? Now, sometimes, most of the time, these are not first time. They will say, no, doctor, I had those episodes before. If they say that they had those episodes before, you have to ask the previous episodes how that happened also. So that detailed history you have to take. So as always, like if I say, is it for the first time? No, doctor, I had a couple of times before. Well, can you please tell me more about those episodes? What were you doing at that time? So you have to get an idea about the past episodes also. That's very important. If it's for the first time, then don't bother with those questions. Go to the next question. So did you lose your consciousness? Because sometimes patient don't understand what is syncope, or patient say that I had a collapse. So you have to actually make sure that patient lost consciousness, because syncope means loosening of consciousness. Okay, so patient can fall, but if the patient doesn't lose consciousness, that will be a pre-syncope, not syncope. Syncope means when a patient lose consciousness suddenly. That means what you in a non-medical word you call fainting. That's the same thing as a syncope. So you have to ask that, well, did you lose your consciousness? Yes, doctor. So how did you fall? Did you fall suddenly, or did you feel that you were lightheaded or feeling dizzy before you fall? Now, what we do that we divide syncope questions into three important questions. One is pre-syncope, so what happened before you lost consciousness? Syncope, so what happened during your lost consciousness? And what happened after you regain your consciousness, which is post-syncope. So these three questions are important. So pre-syncope question will be, what exactly were you doing at that time? Is it for the first time? Did you fall suddenly, or did you feel any lightheadedness or dizziness before you fall? Any headache, blurring of vision, any weakness, any part of the body? So sometimes people with vasovagal syncope usually has those prodromal symptoms. The prodromal symptoms usually comes as feeling lightheadedness, dizziness, and become suddenly pale, hot and clammy, and feeling nauseous and sweaty. And just after that, patient fall. That's a typical scenario of vasovagal syncope. There's a reason you need to ask those questions. So did you feel lightheadedness or dizziness before you fall? Any headache, blurry vision, any weakness, any part of the body? Did you feel nauseous or sick? Did you have sweating? Did you feel hot and clammy before you fall? So that's your pre-syncope question. After that, go to the syncope question. Was there anyone with you who witnessed your fall? So always important. If there is any witness, you will say, okay, if you give me the consent, I would like to ask question to him as well to find out what exactly happened when you lost consciousness. Because patient lost consciousness, patient will be unable to say what exactly happened during that time. If there is any witness, they will be able to say that. Any loss of consciousness? Yes, doctor. If yes, then how long did you lost your consciousness? Any jerking movement of your body? Did you bite your tongue or wet yourself? Did you injure your head when you fall? Very important to ask about head injury, because sometimes patient can fall suddenly into the ground and they can strike the head, and that's one of the important finding that you should not miss. So was there any witness, any loss of consciousness? How long, if there was loss of consciousness? Any jerking movement? Did you bite your tongue or wet yourself? This is for ruling out any epilepsy. That's one of your DD also. For post-syncope question, so after you regained your consciousness, Were you able to stand by yourself or someone helped you? Did you feel confused and drowsy? Any weakness, any problem with your vision or speech after that? Why you are asking this question? If it's a epilepsy, then patient will be confused and drowsy at least more than half an hour after regaining the consciousness. So very important to ask, like, did you feel confused or drowsy after that? Or were you able to stand by yourself or did you need someone's help? This one is for TIA or stroke. So any weakness, any problem with your vision or speech. So that's your pre-syncope, syncope, and post-syncope questions. Good. Now after that, now you go to your differential diagnosis questions. For differential diagnosis, as I said, for each of the DD, one question or highest two question you will ask, not more than that, because you will not have that much time. For differentials, so we have serious differentials. For severe, just ask any chest pain, shortness of breath, any racing of your heart. You cannot ask palpitations because patient doesn't understand that. So you have to always use non-medical word. Very important. Never ever during your history asking use any medical jargon. Otherwise, patient will ask you, what do you mean by that? What is that? Then it will just kill your time. So for serious, any chest pain, shortness of breath, racing of your heart, that will cover every differential diagnosis. So you already asking shortness of breath, racing of your heart, that's for arrhythmia, chest pain, shortness of breath, that's for MI. Okay. For aortic stenosis, usually the triad of aortic stenosis is feeling chest tightness, shortness of breath, and syncope. That's these are the triad of aortic stenosis. So you already asked that also. So all CVS questions are usually falling in 3 or 4 questions. So any chest pain, shortness of breath, racing of your heart. For CNS, if you forgot to ask head injury at that time, don't forget to ask it here. So any head injury, any fever, rash, neck stiffness, that's for ruling out infection, which is meningitis or encephalitis. Okay. Now you already asked all the stroke or TIA question during your pre-syncope, post-syncope questions. So you don't need to ask those CNS stroke or TIA related questions here. You just need to rule out infection, because if you go here, stroke you have asked, head injury you asked, epilepsy you asked during syncope question. Only thing left is infection, that's you are asking now. So after CVS and CNS, then other causes. So one cause is hypoglycemia. So for hypoglycemia, just one question. Did you skip your meal today? Do you have any history of diabetes? All right. So that's for hypoglycemia. For vasovagal syncope, we don't have any exact questions for that because it's a typical scenario where a patient will be exerting in hot weather, having like doing a lot of exercise or running a marathon and suddenly feeling pale, calm, clammy, and then just fall. That's your vasovagal. So we don't have exact questions for that. But if you really want to ask, then you can ask that when that happened, were you in a hot weather? Okay, so that's one question you can ask. That's for vasovagal. Then for postural hypertension, that's a very important question to ask. So do you feel dizzy or lightheaded when you get up from your bed in the morning? Patients with postural hypertension, what happens that when they suddenly wake up in the morning and get up from the bed from their lying position to the standing position, due to change of the position, there is sometimes postural hypotension, which means that when they stand up suddenly, there is peripheral pooling of blood in their lower extremity, which results in low blood supply to the brain. And that's why they feel dizzy. So that's why we ask, do you feel dizzy or lightheaded when you get up from the bed in the morning? Very important question. For anemia, do you feel tired, fatigued these days? For stress, any stress at your home or work? So that's usually covers our differentials. Sometimes infection can cause syncope also. So you can ask infection related questions. Like you can ask any recent fever, flu-like illness, cough or cold. Just just for asking, because sometimes infection can cause syncope also. So that's your differential diagnosis: CVS, CNS, hypoglycemia, vasovagal, Pushual hypotension, anemia, and stress. Always try to remember DD because that's important. So remember in syncope, how you are going to ask: first, hemodynamic stability, making sure I reassure the patient. I ask about pre-syncope, syncope, post-syncope question. I then move to the DD question. I will start with the CVS question, followed by CNS question, then the others. In the others, I have most importantly hypoglycemia, I have postural hypertension, vasovagal syncope, hypoglycemia, and stress. Mainly these five. And then I will move into the format. Always finish with the same format. Ask past medical history, SADMA, and family history. Past medical history, specifically, you need to make sure if patient doesn't say anything, at least ask that do you have any heart condition, any previous history of a stroke, diabetes, hypertension. For SADMA, usually smoking, alcohol, and medication history. So, do you smoke or drink alcohol? Are you on any kind of medications? Very important to ask about medication history, because patients who are elderly, they used to take a lot of blood pressure medications, diuretics, and everything, and they make the patient's blood pressure fall. So, that's very, very important to ask about medication history in detail. And lastly, family history. So, any family history of sudden death, any family history of heart condition. Family history of sudden death is important for HOCM and prolonged QT syndrome. People with a family history of sudden cardiac death, that's a high risk cases, because they can die anytime, and they can die at very young age. So sudden cardiac death history in the family is very important to assess when you ask it in the history. Very, very important. Don't forget to ask it. Now, yes, if you get any positive signs or symptoms, you have to ask differential diagnosis. Okay, so it doesn't mean that you find a positive findings here, like, well, patient is giving you chest pain, shortness of breath, and also syncope, and you think that it could be aortic stenosis, but still you have to ask all other differentials, because it doesn't mean patient only have one diagnosis. Sometimes patient can have multiple causes, so you have to ask all the differentials. Clear? So that's your format. Any questions so far in the format? Dr. Rasa Bakhet, slide is clear is because you are using the Facebook. If you are using the Facebook, it will take some time from Zoom to go into the Facebook as a live session. So it's always better to join through the Zoom. It's very easy. We have given you the Zoom ID. You just need to insert a Zoom ID and you will be able to enter into the Zoom. All our sessions will be in the Zoom. So try to join in the Zoom rather than joining in the Facebook, because Facebook, it will be a little bit of delay. Good. So the vasovagal syncope, Dr. Samrin Arian, the vasovagal syncope means that patient usually will exerting in somewhere like in a hot weather, doing some exercises, or patient is already very very tired and fatigued because of exercise or doing a lot of hard work, or doing some stressful work, and then suddenly what will happen, or patient was standing for a long period of time, so suddenly patient will start to have those prodromal symptoms, which means that they will be hot, cold, and clammy, and then they will be kind of pale, and They will feel lightheadedness, nausea, and sweaty. Just within couple of seconds, patient will fall, and then they will again regain consciousness within few seconds. That's your vasovagal syncope. We have case for vasovagal syncope. We'll discuss that in detail. Dr. Cookie, no, you don't need to ask serious questions in the pre-syncope questions because you are asking it in the DD question. Wherever you ask, you have to ask it. But chest pain, shortness of breath usually doesn't happen in the pre-syncope, so we don't need to ask it. Good. So that's your format for your history for all syncope cluster. After you have done that, go to the PEFE. For PEFE, always try to remember how you are going to ask. So when you finish your history, always thank the patient for all this information and say that thank you so much, John, for all the information. Now I'm going to talk with my examiner and I will come back to you. Examiner, I would like to know the general appearance of my patient. Most of the time, examiner will say, as you can see, or patient examiner can say patient seems to be distressed, patient seems to be comfortable, whatever they want, they will give it to you. After general appearance, there is pickled. The pickled is a mnemonic for a multiple general appearance, which P for pallor, I for icterus, C for cyanosis, clubbing, lymph node, edema, dehydration. You don't need to ask all those things here. So no need to ask everything. It's just the relevant pickled questions you will ask. For a patient with syncope, what are the important pickled? Very important is to ask the pallor because anemia is one of your DD. So any pallor you can ask in one go. So any pallor, icterus, cyanosis or lymph node, just in one go. But for this case, only relevant pickled is pallor. Others are not very important. You can ask about edema because it can be related to heart. That's all. After pickle, then you go to the doctor. I would like to know the vitals of my patient, blood pressure and pulse rate, respiratory rate and temperature, and oxygen saturation. Always ask two by two. That means pulse and blood pressure, respiratory rate, temperature, and then oxygen saturation. Don't ask all together. It will be a like very confusing. Don't ask like, doctor, I would like to know the vitals of my patient, pulse, blood pressure, respiratory rate, temperature, saturation. Some candidates do that. So don't do these things. Always when you ask any questions, maximum in one go, two questions you can ask. Then always I keep BMI because it's important in some of the cases and it can give you some information about patient body status and if they are losing any weight or not. But for this case, BMI is not very important. Now, if you already ask the vitals in your starting, what you need to do that you need to just ask that, doctor, is the vital same like before? Okay, so that's one of the thing you need to ask. Otherwise, you don't need to ask again blood pressure, pulse, respiratory rate. Just ask that, doctor, is the vital same like before? It will save you some time. After that, go to the neck because for any cardiology, the examination will have the similar format. So start with the neck for JVP and carotid bruit. So doctor, I would like to know, is JVP raised? Is there any carotid bruit? I would like to do whole body systemic examination, but I will focus on cardiovascular system, starting with the inspection. Is there any visible cardiac impulse? No. On palpation, is the apex beat normal in position? Any palpable thrill? Any parasternal hip or palpable P2? On auscultation, apart from S1, S2, is there any added sound like murmur or pericardial rub? Very, very important not to forget murmur in this case because you have aortic stenosis as one of your DD. So murmur is must to ask here. And normally others usually don't give you any finding. Parasternal hip, palpable P2, these are for mainly pulmonary hypertension. So usually we don't have any case for that. So, but as a normal systemic exam, we ask this question. You have to ask it in detail because it's a cardiac case. Your cardiovascular system, you have to ask like inspection, palpation, auscultation. But the other system you will just ask in one go. So the next important one is CNS. So doctor, I would also like to do full central nervous system examination, including the cranial nerves. If they ask, what do you mean by that? Or what do you want to know? Then just say ITPRCS. What is ITPRCS? Inspection, tone, power, reflex, coordination, and sensation. That's what you look for in CNS examination. We will do CNS at that time, we will discuss it in detail, but right now just remember ITPRCS is our CNS examination. So inspection, tone, power, reflex, coordination, and sensation. And then you can say that, doctor, I would also like to do other systemic examination like respiratory system and abdominal system. Normally, examiner will say skip or they will say it's normal. You don't need to go in detail. Is there any office test available like urine dipstick, blood sugar, and ECG? Now, obviously, office test is must to ask after finishing your PEFE. PEFE means physical examination from examiner. So for PEFE, office test is must. Now, office test, we have 5 or 6 office tests. So these are 3: urine dipstick, blood sugar, ECG, then you have spirometry and urine pregnancy test. These 5 are only the office test. Sometimes ABG is also office test, but for AMC, we don't need to ask ABG. But you will ask, in this case, most important is this one, ECG. Don't forget to ask ECG in a cardiac cluster. So urine dipstick, BSL, ECG, and other 2 office tests is relevant. Like if you are asking a gynae ops cases, then urine pregnancy test is very important. And for respiratory cases like COPD, asthma, we ask spirometry. So that's your office test. So you will say, doctor, is there any office test available like urine dipstick, blood sugar, and ECG? And then you thank your examiner. And then you come back to the patient. Whatever you think the diagnosis is, you explain it to the patient. Until now, is this clear for everyone, the history and physical examination? Because after that, everything will be similar, like how we have done the history and physical examination, and then we will just discuss the management. This is how we can finish 4 or 5 cases in one go. Yes, Dr. Mohak, with the new online platform, yes, it's possible because there will be a invigilator or a case manager with you throughout your examination, and the case manager will give you all the finding. So you will ask it from the case manager. It's called office test because it's bedside. But do not include X-ray in your office test because you normally you don't do X-ray in your bed. We do mobile X-ray, but that's not for everyone. But office test means that what you can do in your bedside. All good. Those who are in the Facebook also good. Great. So now we move into the cases. First case is aortic stenosis. For aortic stenosis, the question is like this. So you are a GP and your next patient is a 52-year-old male who is consulting about a recent loss of consciousness. So you got your case. So recent loss of consciousness means syncope. So it's a syncope case. Now your task is history, PEFE, investigations, diagnosis, and management. Never ever this much detailed task comes in the exam. Always one or like two or three most likely, but never ever four tasks like this comes in the exam, because you will not never ever will be able to finish it in time. But we need to know everything. The positive point for aortic stenosis will be like patient was playing tennis and then started to black out. So that's the loss of consciousness. Patient also will give you that patient feel exertional dyspnea or shortness of breath for the last 2 months. So mainly when he do some exercise or when having some exertion, he feels dyspneic or shortness of breath. And also during that time, patient feels chest tightness mainly or spasm rather than full-blown chest pain. So that's a triad of aortic stenosis, chest tightness, exertional dyspnea, and also syncope. If you go into the PEFE, you will find out there is a murmur. So it's a for aortic stenosis, the murmur is a ejection systolic murmur in the aortic area that will radiate to the neck or carotid. And sometimes you can get the apical impulse displaced and forceful. That's not very important, but finding the murmur is very important. Now, how you ask murmur from an examiner, that's also important. So when you ask, apart from S1, S2, is there any other added sound like murmur, pericardial rub? Patient examiner says, yes, there is murmur. Then will you ask in detail? Yes, you have to ask in detail. Otherwise, how you will know what type of murmur or what type of valvular disease this patient is having? So you have to ask, doctor, I would like to know, is this murmur is a systolic or diastolic? Examiner says systolic. So is it a ejection systolic or hollow systolic murmur? Examiner says ejection systolic murmur. Okay. Can I know the site of the murmur and is there any radiation? So site is aortic area and radiating to the neck. Now you know that what is the valvular condition this patient is having. If you get time, you can also ask like, does the murmur change with position or respiration? And what is the intensity of the murmur? But these are not very important. This is very important to know the type of murmur, like is it a systolic or diastolic? If systolic, then is it a ejection systolic or hollow systolic? Ejection systolic is aortic stenosis, hollow systolic is mitral regurgitation. So very very two different things, we need to ask it. Otherwise we cannot definitively say in our explanation that this patient is having AS. So your diagnosis depend on this question. So it's a key step to find it out. All right. Now you explain. So how you are going to explain aortic stenosis? Say, well, thank you so much for all your information, John. Now, from your history and physical examination, I'm thinking most likely you are having a condition called aortic stenosis. Do you know what it is? No, doctor, what it is? Well, don't stress. I'm going to draw a picture for you. So always try to draw a picture. You don't need to draw a very nice and beautiful picture. Just draw so that you can explain it to the patient better. So draw the heart and you say, well, this is your heart. Like anything you can draw. Okay. I used to draw heart like this. So you can draw like this, say that this is your heart and your heart has 4 chambers. Each of these 8 chambers has a door-like structure called valve. In your case, the valve that controls the flow of blood from your heart to your aorta, which is your big blood pipe that supplies all your body, is narrowed. So when you explain, you also draw. Okay, so you have 4 chambers in your heart. In your case, the valve that controls the flow of blood from your heart to the aorta, called aortic valve, has been narrowed. That's why the blood supply from your heart to the brain is being reduced, which is causing your frequent loss of consciousness. And when you exercise, the demand of oxygen from the heart gets increased, but already your heart valve is narrowed. So your heart cannot supply enough oxygen and blood, which results in chest pain and shortness of breath. See that always try to correlate the your explanation with the patient's symptoms so that patient understand why I am having frequent collapse, why I am having shortness of breath or chest pain when I work. So your explanation is not just explaining things like just saying definition of a condition. It's not like that. Your explanation should correlate with the patient's symptoms so that patient understand why I am having these symptoms. That's one of the important thing most of the candidates forget to do. So in this patient having collapse or syncope. Why? Because if the aortic valve is narrow, the blood from the heart cannot go to the aorta, and your aorta supplies your brain, right? So if from heart to the aorta not enough blood is coming, your brain is not getting enough blood, so you are having loss of consciousness frequently. And the other two symptoms, shortness of breath and chest pain, which comes mainly in exercise, because exercise increases the oxygen demand, but already blood supply from heart is reduced. So during exercise, with the increased demand, patient feels more shortness of breath and chest tightness. After you explain it, then say, well, it could be due to other causes as well. Now, I'm giving you two scenarios. One of the task will be just explain the diagnosis and give differential diagnosis. That's most of the time the exam questions. But sometimes if they ask the management, then you have to explain detail about the management. Just an overview, not the total management, just overview of the management. But most of the time as the DD comes, you have to say, well, this could be due to other causes as well. Like, so you go to your differential diagnosis, then you will start explaining all the DD and say why these DD are not your provisional diagnosis. So it could be due to arrhythmia or your heart rhythm disturbance, but your ECG looks fine and you don't have any racing of your heart. It could be heart attack or myocardial infarction, but your ECG looks fine. You don't have any chest pain, or you don't have any typical chest pain of heart attack. It could be any structural heart disease called hypertrophic obstructive cardiomyopathy, but you don't have any family history of sudden cardiac death. It could be any rhythm problem you already asked, because prolonged Qt is also rhythm problem, so don't need to ask, no, don't need to discuss it again. So finish here and then say, well, it could be due to a stroke but you don't have any weakness of your body, could be head injury but you did not hurt your head, could be infection or epilepsy but your symptoms doesn't go with that, could be postural hypotension, but your blood pressure in sitting and standing is normal. Could be hypoglycemia, but you did not skip in any meal or you don't have any diabetes. Could be anemia, but you don't feel tired or fatigued and you don't look pale. And it could be also medication induced, but none of the medication you are taking seems like causing your syncope. So see that this is how you have to explain differential diagnosis. That's very important. There is no hard and fast rule how you say that. That's why I haven't written anything here, because it's just you already asked questions of differentials. You haven't found any positive findings in those questions. That's only thing you are just saying to the patient, that you are showing it to the patient how you ruled out other DD. Not only that, also to the examiner that how I came to my provisional diagnosis. This is the main part, because this is your last task, and that determines a lot that you pass or fail this station. Very important, whenever you discuss differential diagnosis, please try to follow how I did. This is very, very well appreciated. After that, if the task is DD, then you finish there. Don't go into saying the management or investigation, because it's not your task. You should not say it. If you start talking about management, most of the time the examiner will say, stick to your task, stick to your task. Now, if management comes, what is the management of aortic stenosis? So you need to refer the patient to the hospital if you are a GP setting to confirm your diagnosis. What are the investigation they will do? So normally always use the word send rather than referring. So you will say, well, I would like to send you to the hospital to confirm my diagnosis and rule out other causes. In the hospital, you will be admitted, you will be seen by the heart specialist, and they will do some investigation. What are the investigation they might do? Full blood examination. These are basic blood tests. Everyone will get it. Full blood examination, kidney function test, ESR CRP, electrocardiogram or ECG, chest X-ray, and an echocardiogram to confirm your heart valve condition. So mainly for this case, ECG, chest X-ray, and an echocardiogram will be very important. After you have done those investigations, the cardiologist will be able to formulate a plan of management for you, depending on the degree and narrowing of your uh, narrowing of your valve and severity of your condition. Further management will be discussed in detail with you by the cardiologist. So see that you don't need to say exact what are the management. For aortic stenosis, if it's causing this much symptoms, patient will need valve replacement. So you can say that, well, depending on their severity and degree of narrowing, further management will be tailored by your specialist. Most of the time, because you are having symptoms, and depending on the severity or of your stenosis or narrowing of the heart valve, specialists might decide to do a valve replacement. But I'm just a junior doctor. Usually the specialist will talk in details about you. Now, once you are stable and discharged from the hospital, I will regularly follow you up. Please try to adopt healthy lifestyle and avoid any strenuous activities. Okay, and these are the reading materials you can read when you are going to the hospital. So we always try to finish with 4R. But if a patient is going to the hospital, you don't need to give all the 4R. But if the patient is discharged home from your GP setting, then all the 4R is very important. What is 4R? 4R, 1R is review. So when you are again reviewing the patient, another R is referral. So are you going to refer this patient to any specialist? Another R is red flag. So what are the red flags that will prompt me to come back to the ED or to your GP clinic again? So for this case, not for this case, so for like other syncope cases, you will say if you are still having frequent collapse, if you're feeling very unwell, having chest pain, shortness of breath, please come back to me or go to the emergency department immediately. That's your red flags. That means the symptoms which are very sinister. And lastly, give reading materials about the condition so that patient can have some idea when they are at home. So this 4R is vitals for any cases. When you finish your explanation, then you give 4R. But as this patient is already going to the hospital, you don't need to give red flags at this time. Clear everyone, aortic stenosis, any question? So Dr. Jeb, if it is hospital admission, in the case, do we say in the start of explanation? No, you explain it first, and during your management, see that in here I said I would like to refer you to the hospital. So you don't need to say that. You will say I need to admit you to the hospital. That's only the change if this is the hospital setting. And always, if you are a junior doctor in the hospital, like hospital medical officer, or you are a JHO, junior house officer, or resident medical officer, whatever, these are the junior position. In junior position, always when you admit patient, always ask help from your senior. So always say, I would like to discuss with my senior and probably admit you to the hospital. Can I directly ask examiner by mentioning ejection? No, Dr. Amjad, that is one of the important thing I was going to say. Don't ask directly. If you ask directly, it already shows that you know this case, okay, and that's you are just giving it like just by memorizing. Because there is no way you should ask it this much directly that doctor, is there any ejection systolic murmur relating to the neck? No, we don't do that. We will go in one by one so that examiner also feels like, well, he knows the approach and a stepwise approach to ask murmur question. Great. Any questions so far? Dr. Arushi, yep, the time is very limited. So it depends on what are the tasks you are having. Most of the time, if it's a DD, what they ask history, physical examination, diagnosis, and differential diagnosis. In that case, you will have time to explain that. But again, if your times run out, then you will just give the DD. Just in within 30 seconds, just say all the DD that you asked. Finish your DD, then still you are having time, then you explain that how you ruled out. So you have to be very smart during your exam. If you will, once you start doing role play, you will feel like you will know by without looking the watch, you will know that how much time I might have left. Okay, that will come in your mind eventually. And then you will, if you feel like, well, there is not much time left, finish the DD because that's your task. At least say couple of like 6 or 7 differentials. After that, you still have time, then start with explanation that this is why I don't think you are having MI. This is why I don't think you are having HOCM. Okay. So that's one of the important thing that you can do. But management PEFE diagnosis doesn't come in one setting. So you will get enough time. Those who are in the Facebook, you guys are able to hear any confusion, any problem you are having. Yes, if you skip task, you fail the station, obviously. You have to finish your task because your marking depends on your task. So most of the time, if you skip, probably you're going to fail that station. Next case is prolonged QT syndrome. Prolonged QT syndrome, always the case will be like this, like teenagers or adolescent patient comes to you because she fell unconscious 2 days ago while she was climbing up a mountain. So she was climbing up a mountain and then she lost consciousness. That's one of the very typical scenario of prolonged QT syndrome. Again, the task is kind of similar. Sorry. So I've got some questions. So Dr. Sambreen Arian, how we can ask about murmur. So the murmur questions, as I said earlier, so you have to ask, doctor, is there any murmur? Yes. Is it systolic or diastolic? So examiner says systolic. Then you say, is it ejection systolic or hollow systolic murmur, doctor? It's ejection systolic. Doctor, I would like to just confirm the site of the murmur and if there is any radiation. If you want and if you have time, you can ask intensity of the murmur. You can ask, does the murmur change with respiration or change of position? If history of fall, mainly if there is history of fall with a head strike to the ground, then you can ask in the PEFE, is there any sign of head injury? All right, Dr. Shamima Sultana. Great. Now move to the prolonged QT syndrome. For prolonged QT syndrome, this is how the scenario looks like. Now see that what could be the positive findings. So patient was climbing up a mountain, then suddenly lost consciousness. If you ask that, is it the first time? Patient will say no, it's been happening for like 3 or 4 times so far. So patient had it before. So you have to ask in detail, can you please tell me in detail what exactly were you doing in each of those episodes? So very important to find that out. And you will find out we're doing different things each time, but still she had those unconsciousness. No shortness of breath, chest pain or palpitations. History of unknown heart disease in maternal uncle. So that's one of the very important clue. That patient had a unknown heart condition and possibly this maternal uncle also had a sudden cardiac death. So that's one of the finding. In the PEFE, no murmur, but ECG, they will provide a ECG to you and you will get a prolonged QT syndrome in ECG. So nothing will be positive apart from those, from that syncope, and also patients have a family history of heart condition or heart disease with a sudden cardiac death in early age. And in the PFE, no murmur, no findings, just everything is normal, but ECG, you will get a prolonged QT. Clear? So that's how you will come across and you will find out your case. Now for the ECG cases, you have to have a little idea about this ECG. So as you see that, I think most of you know because you passed your AMC MCQ, in which case you should have a good ECG knowledge. Now for normal ECG, you know that this is the P wave, then you have QRS complex, then this is T wave. For this particular case, you need to know how to measure QT interval. Now your QT interval, if you draw a line from Q wave up to the end of the T wave, this whole is your QT interval. In a normal person, the QT interval should be 8 to 11 small square. That's how you should remember. Don't remember by seconds or time. 8 to 11 small square is normal. And sometimes if you get the ECG from the examiner, have a look at the ECG because sometimes they give you the finding in here that QTC is 440. So that's what, oh my God, what happened? Sorry. So sometimes in here, they give you the corrected QT interval, which is QTC. In the ECG, have a look that if it's written or not, because if you get that, then it's very easy to diagnose. So QTC is prolonged if it is more than 440 millisecond in case of men and more than 460 in case of women. So that's why make sure you remember that because sometimes in the ECG paper, these informations are given. Good. Now, if you look at this ECG, what you can find out, always when you look at the ECG, important thing is to look at is this lead 2, because lead 2 is your rhythm lead, and also look at from V1 to V6. Give just give a eyes look to see if there is any visible ST elevation. But remember, this patient came to you with a syncope. Although MI patient can come to you with a syncope, but obviously there should be having some chest pain, shortness of breath, right? As this patient doesn't have that, in your mind, it should be like, well, as they have given me the ECG, it should be related to something arrhythmia. So, and what arrhythmia causes the sort of sudden loss of consciousness or having family history? QT prolongation. So in your brain, it should work during your history that in the ECG, I will look for QT prolongation. This is how your brain should work in the exam. Otherwise, very difficult, because ECG reading, if you want to read perfectly, it takes like about 1 minute, but you don't have that much in your exam. In just 15 or 20 seconds, you have to finish your ECG reading and explanation. So I know that this case is like, this probably is not a MI or any ISD case. So what I'm going to do, I'm going to look at the lead 2. In the lead 2, what I will see first, I'm seeing that RR interval, right? These are RR interval, and RR interval looks good, like 1, 2, 3, 4. There is 4 large square, right? And measuring heart rate is very easy just by remembering this formula. So if you get only one large square between RR interval, just one large square is 300, two large square is 150, three large square is 100, four large square is 75. So if there is four large square, probably the heart rate is 75 here. And I can see it's regular. So it's not AF that I know. So if it was AF, it should be irregular. It's not AF. The rhythm is fine, heart rate is fine. Now, what else could be? The ST elevation is not there. Good. Now, let's look at the QT interval, right? Now, for looking at the QT interval, see, this is where it will start and this is where it will finish. So, how much small square is there? 5, 5, 10 plus 5, 15 small square. Now, if it is a 15 small square, it's more than 11 small square. So, this patient is having prolonged QT syndrome. Clear, guys? So this is how you should come across, or you come across a diagnosis. Always think very, very fast, but effectively. So like your scenario will give you the diagnosis and you just need to confirm it with the ECG. Okay. So once you get the scenario, just look at the rhythm strip, look at the heart rate, measure it with, like, you know already how to measure it. See that it is rhythm is regular or irregular, and I can see that there is P wave is present here. QRS complex is fine. There is no ST elevation or ST depression. T wave is also looks good. So everything is normal. So what's the problem? So look at the QT interval. So the prolonged QT, you measure it. So see this one, your QT interval is from your Q wave, starting of the Q wave to the end of the T wave. This is your QT interval. Normal QT interval is 8 to 11 small square. In this case, if you see here, this is the Q. Sometimes you will not be able to see Q wave because normally Q wave only comes in old MI. So just find out the R wave in starting of the R wave. and then move to the end of the T wave. This is the end of the T wave, right? And then measure the small squares. Again, if you go through here, this is the Q wave starting, and this is the T wave, right? So it's obviously it's more than 15, more than 11 small square. So this is how you should measure it. So normally not up to this, up to this. This is the end of the T wave. Okay. So this is the end of the T wave. This is the Q wave. Again, it's 15. Like I would say 5, 5, 10, 11, 12, 13, 4. Yeah, 15 will be fine. So because you will be given this ECG in online, okay, they will give it obviously a clear ECG and always try to find it out. Is this clear for everyone? Now we will go through the palpitation cluster and I will show you how to explain ECG to the examiner, because sometimes explanation of ECG to the examiner is a task. Now when you explain this case, because you know the diagnosis, so you will say, well, from the history, physical examination, and also from the electrocardiogram, I'm suspecting you are having a condition called prolonged QT syndrome. Always say, I am thinking or I am suspecting, because that is your provisional diagnosis, not your confirmatory diagnosis. So always say, I am thinking, I am suspecting. Clear? Then you will say, do you know what it is? No, doctor, what it is? Well, let me explain it in detail. See, this is the electrocardiogram of your heart, which is the recording of your electrical activity of the heart. Let me draw a picture. Draw the heart very quickly. Draw the SA node, AV node, Purkinje fiber, whatever it is, just draw something. Okay. And then say, this is your heart. Your heart has electrical activity to pump the blood to the whole body. And this ECG has different parts which represents different components of this activity. In your case, one of the part in the ECG called QT interval is markedly prolonged, and we call this condition as prolonged QT syndrome. This condition is commonly associated with abnormal heart rhythm, resulting in impaired pumping of blood, and that causes frequent collapse like in your case. You'd never ever go into detail of the ECG explanation, because for a person who doesn't have medical background, that means the patient should not know anything about ECG, and it will be very hard for them to understand. So you don't need to explain ECG different parts, P wave, Q wave, no need. You will just say in this way, in your case, the part called QT interval is markedly prolonged, and that's why we call it as a prolonged QT syndrome. This condition causes impaired heart rhythm, resulting in abnormal pumping of blood. So as there is abnormal pumping of blood from your heart, your brain is not getting enough blood. That's why you are getting frequent collapse. Sometimes this condition runs in the family, which we call congenital prolonged QT syndrome, or sometimes it can be also due to some medication, dehydration, salt and water imbalance. In your case, because you have been uh, you have been climbing the mountain, and probably it would be a hot condition, and you have been exerting, so most likely you were dehydrated and your salt and water was imbalanced, and that might be the cause of your collapse at that time. But unfortunately, I cannot say it unless I do more investigation. And unfortunately, this condition sometimes can cause serious consequences. And that's the reason I need to admit you to the hospital, call my senior, and also the heart specialist will review you. Please don't worry, you are in a safe hand and we will do our best to manage your condition. The specialist might do few investigations. What are the investigations usually we do? Basic blood, full blood, kidney function, and a echocardiogram. So echocardiogram is very important to see the status of the heart function of the patient. Management, he might start you on some medication called beta blocker, and if that fails, he might put you on cardiac pacing as well. I know this is all overwhelming for you at the moment. Please don't worry, we will discuss it in detail once we can confirm your condition. If every investigation comes normal, we don't find any cause, probably it's your by birth defect, which usually runs in the families. And in that case, we will do some family screening by doing ECG to find out if this condition running in families or not. All right. Normally, management of QT syndrome doesn't come in the exam because it's a little complicated one. So don't bother with that. Just remember how you can explain if it comes anytime. Management of QT prolongation is doing all those investigations. If no cause found, that's congenital prolonged QT. In that situation, you don't need to do anything. Just arrange the family screening. And obviously, the definitive management is beta blocker. Try the beta blocker medication. If that doesn't help, then cardiac pacemaker. Clear, everyone? So this is how you should explain any of these heart related condition like QT prolongation, or sometimes we will get SVT, we will get atrial fibrillation. All these things we will not go in detail of the ECG. We will just say that this happened and it causes impaired pumping of the blood, resulting in lack of blood supply to your brain, and that's why you are getting frequent collapse. Any question? All good? Great. I got a question. So in AMC, do we have the case of prolonged QT for old people? Also, can prolonged QT result from medication? Yes, prolonged QT can result from medication. A lot of medication can cause prolonged QT, especially some of the antibiotics like erythromycin. mm, Most of the antibiotic in the penicillin group can cause it. And also electrolyte imbalance can cause it. So medication, yeah, there are a lot of medication which can cause prolonged QT. One of those are important. But for AMC, usually older people doesn't come, but obviously you should always keep a broad mind when you appear at the AMC. It can come to anyone. But most of the time, it's the younger population who comes to you with a prolonged QT syndrome. Good. Now, we'll take a 10-minute break because we have been talking a lot throughout this time. So I'll take a 10-minute break and then we'll discuss the other cases related to syncope. And we will start the palpitation cluster, just the cluster, not the cases. so that we can finish it in the next sessions. Okay, so let's take a 10-minute break. Thank you. Okay, so let's start again. So now we're going to discuss the Pushual hypotension case. Now this case is very important for the exam. Among all the cases we discussed so far, this is one of the most important one. So a middle-aged woman comes to you with feeling dizziness or lightheadedness for the last several days. So anything like sometimes they can come to you with just feeling dizzy or lightheadedness, or sometimes they can come to you with exact fall cases. So both of these are postural hypotension case. Now positive points in postural hypotension, one is that patient feels dizzy when they stand from a sitting or lying position. Patient also says that patient has been diabetic for many years, but it's well controlled. Patient is on some medication, metformin, aspirin, diuretics, and ACE inhibitors. History of heartburn, loose stool for a while, but there is no blood in the stool. Why you are asking that? Because postural hypertension, feeling dizziness can be related to anemia, and in elderly patient having anemia, most of the time we want to know that if they are having any melena or any blood in the stool. And then in the PEFE, only positive finding that you have got is postural drop. So that's one of the history. Now, in this case, having diabetes also makes you a little complicated case because sometimes diabetic patient can have autonomic neuropathy, and autonomic neuropathy can cause postural hypotension. So it's very important to ask some of the autoneuropathic questions when you ask this question, the other differential diagnosis. Just because because the patient will say that, well, I feel dizzy when I stand up from sitting position or lying position. No, that's a postural hypotension. Once you get postural hypotension, then you need to find out the causes, why this patient is having this postural hypotension. Most important cause is medication, especially blood pressure medication, like your ACE inhibitor, diuretics, both of these two can cause it. So if you get a medication like this, you have to assess that if any of these medication has been started recently, or any of these medications dose has been increased recently, because that will explain why the patient had a fall now. Clear? So that's one of the things you need to ask if you get medication. Otherwise, some other causes of postural hypertension, one, it could be if the patient is losing blood. So obviously we need to ask history of peptic ulcer disease or heartburn. Is the patient taking any NSAID, and is there any blood in the stool? And is the patient is having any anemia? Getting diabetes, also we need to ask some of the questions related to diabetic autoneuropathy. Diabetic autoneuropathy patient has feeling of like in like very early satiety or early gastric emptying. Patient usually have diarrhea, vomiting. Sorry, not early gastric emptying, delayed gastric emptying. And then also patient can have diarrhea, constipation. Most of the time they have sexual dysfunction. Okay, so all those questions we will ask in our history. I'll show you what are the questions we need to ask. That's mainly your three important causes you need to find out. And after you find out the causes, then move into the all the other differential questions. Now, another history could be patient who was sitting in a chair. While standing from a sitting position, patient collapsed. That's also one of your case. Now, from sitting to standing, if patient falls, that's postural hypertension. If in the charts, patient was standing for a long time and then collapsed, what is that called, guys? Then what you should think? Patient was standing in, yep, Dr. Farah, good. So vasovagal syncope. So this is very important to understand the open. the questions when you say what exactly happened. So we need to find out how she or he has collapsed. Another recall is patient was taking risperidone for psychiatric issues, now comes with history of dizziness. Now, risperidone is a very notorious drug to cause Pushual hypotension. So that's also one of the important questions we need to find out if this patient is taking any other medication like psychiatric medication. Good. So let's see. For the first case, remember all these cases, everything will be normal in the physical examination apart from postural drop. Now, if you don't ask postural drop in the PEFE, you miss the only one finding. That means you missed one of the key steps. So remember always postural hypertension or syncope cluster, always ask postural blood pressure. Now, for the first case, we will say most likely you are having a condition called postural hypertension. Do you know what it is? No, doctor. Well, this is a condition in which there is sudden drop of your blood pressure when you change your position from lying or sitting to a standing position. Now, it could be due to many reasons, like if you are vomiting severely, having diarrhea, having high fever or any infection, strenuous exercise, okay, losing blood from anywhere. But in your case, I'm suspecting is due to the multiple medications you have been taking. So see that how I am saying. So what is the cause of it? It could be due to many reasons. Like if you have severe vomiting, diarrhea, that will cause dehydration and can cause postural BP loss, like postural hypotension. And also it could be it could be high fever or any flu-like illness. So infection can cause it. Strenuous exercise can cause it. But in your case, most likely the multiple medications you are taking, probably that's the cause. On the top of that, you are also diabetic. So it could be due to another condition called diabetic autoneuropathy, which is a complication of diabetes, and it can manifest as heartburn, blotting sensation, diarrhea, constipation, difficulty passing water, and also sometimes sexual dysfunction. But as you said, your blood sugar is well controlled, so I'm thinking it's less likely. So the medications you have been taking, the blood pressure medication, most likely that's the cause of your frequent collapse. Now, this type of dizziness or fall could be due to other reasons, like it could be heart rhythm disturbance, structural heart disease, heart attack. But in your case, I don't think you have it because you don't have any symptoms associated with it. It could be a stroke, you don't have any weakness, could be seizure, but you don't have any fit or jerky movement, could be head injury or infection, but less likely in your case. Also, it could be vasovagal syncope, but you were not exerting or you are not standing for a prolonged time. So I'm thinking it's less likely to be a cause of vasovagal syncope. So in this case, what I'm going to do, I'm going to do some basic investigation. What are the investigation I can do? Full blood examination, ESR CRP, kidney function, blood sugar level, liver function, and the ECG. Remember the basic blood test always we do. What are the basic blood tests? Full blood examination, kidney function, liver function, blood sugar level, thyroid function, and sometimes if relevant, ECG. Thyroid function also in relevant cases. So these are the basic blood tests you will do, and do a ECG is very important in here. And then also we will consult with your specialist who has started the medication to review the medication so that we can change or reduce the dose. All right. So if it's a GP setting, you don't need to send this patient to the hospital because you know that it's a medication induced cause. So you can do this investigation, follow up the patient, and consult with the specialist to change or review the medication. Cool. After that, you can say that, well, after the investigation results come back, then I will again review you, give the reading materials, red flag, that's all, and then finish it. The second case, is the side effect of the medication. So again, it's a postural hypertension and it's characterized by change of blood pressure when you stand up from a sitting position. There are two possibilities. One, that you are having a side effect of the risperidone because risperidone itself can lower down your blood pressure when you change your position, or there is a chance you might be taking higher than normal dose that has been prescribed. The side effect is quite common within the first few weeks of the treatment, even if you take a normal dose. So what I need to do, I need to talk with your doctor. I need to find your medication prescription to see what is the dose you are taking. And also, as your wife, in this case, wife was taking care of the medication. So you need to talk with the wife also. So in your case, I also would like to talk with your wife who takes care of your medication if you give me the consent. Anytime in the AMC, you want to discuss about patient's condition to anyone, even wife, daughter, son, anyone, always add with your consent. And then keep the patient in the emergency department to observe the blood pressure, do some basic blood test, call the psychiatric team to review the medication. Now, sometimes what they will do, the psychiatrist can adjust the dose of the medication, or they might want to switch the medication to another medication. Whatever they will do, the management will be done by the psychiatrist. Management, like general management for postural hypertension doesn't come in the exam, but you should know that what are the advice you can give to a patient who is having this sort of postural hypertension. So, first of all, take medications exactly as prescribed. Have a routine to take at the same time every day. If you forgot to take a dose, take it within the next few hours. Otherwise, skip the dose. Do not double the dose. Never stop the drug abruptly. Inform your doctor if you develop any side effect. Now, this half-minute rule is for any postural hypertension causes. So you can follow the half-minute rule, which is when you get up in the morning, sit up slowly, stay there for 30 seconds, put the legs over the side of the bed for 30 seconds, slowly get up, and then walk slowly to prevent any dizziness in the future. So it means that why the patient is having sudden change of their position. So you are asking the patient to wait a little bit for each of the change of position. So patient is lying, from lying to sitting, patient will sit slowly, wait there for 30 seconds, then put the legs over the edge of the bed, again wait for 30 seconds, and then slowly get up. When they get up, again wait for 30 seconds, and then start walking. That will prevent the postural dizziness that he is having. Clear, guys? Any question from postural hypertension? So postural hypertension cases usually will come to you with a like history, PFE diagnosis and differential diagnosis, or diagnosis with reason. So diagnosis with reason means you have to say that you are having postural hypertension, explain what it is, then say what are the causes. So anything reducing blood volume, which means it could be any bleeding from anywhere, any excessive sweating, excessive diarrhea, vomiting, okay? And also if the patient is doing a lot of strenuous exercise, then obviously medication and diabetic autoneuropathy. Sometimes if patient has Parkinson disease, that can also cause this sort of postural hypertension. If the patient is taking risperidone, having psychiatric background, that can also cause it. So always explain the causes and always say what is the most likely cause. For your patient, most likely is the medication. Any question, guys? Let's move on to vasovagal syncope. 18-year-old girl fainted during marathon marathon running during your annual sports. Now fully recovered, mother came to consult you. So 18-year-old girl, while doing the marathon running, she fainted. Mainly fainted means lost consciousness. So now the patient is totally fine, but mother is here to consult with you. History PEFE tell possible causes. Yeah, all these cases we are doing, Dr. Najia, history is same. Because we are doing a cluster, history will be all like pre-syncope, syncope, post-syncope, asking the DD questions. Now, if you get anything positive, you will need to ask a little detail. Like if you get postural hypertension, you need to ask the causes of postural hypertension. That's the only thing that you need to add in every cases. Is same, doctor. Dizziness, like patient can have the same type of complaint. Now if a patient is feeling dizzy, you just need to amend your question. All right, so in that situation, if the patient did not lost consciousness, just feeling dizzy, what you need to ask that, can you please tell me more about your dizziness? What exactly happened when you feel dizzy? Okay, that means now you are asking pre-syncope question. Along with the dizziness, do you feel lightheadedness? Do you feel any blurry vision, any headache, any weakness anywhere in your body? No, doctor. So anytime have you fall and lost consciousness related to your dizziness? No, doctor. If no fall, you don't need to ask that questions of biting tongue, jerky movement. So, and then also post syncope question will not be relevant at that time. So you will just move on to your other DD question, which is your, well, is your dizziness related to change of position? Most of the time, if the dizziness is the only complaint, that's a postural hypotension case. Okay, so then you need to ask those questions. So all the differential diagnoses you will ask one by one, as we discussed. Some of the time with the dizziness, you need to make sure that patient doesn't have any peripheral causes of dizziness or lightheadedness, which means that any problem with the balance, any problem in the ear. So you just need to add those questions. So what are the ear related question you can ask? So do you have any loss of hearing, any ear pain, ear discharge, any history of infection in the ear, do you feel any ringing noise in your ear? That's your tinnitus. And any problem or any difficulty with your balance. So for peripheral causes of lightheadedness or dizziness, we just ask these questions, ear related question, because that's only thing that is different from the syncope caused cases that we are doing. As it's a syncope cluster, not a completely dizziness cluster, but the differentials are pretty same. Just for only dizziness, we need to ask peripheral causes of dizziness, which is your any ear pain, ear discharge, any loss of hearing, any problem or difficulty with your balance. Okay, and then what you need to do, you need to ask about any past history of ear infection and any ringing noises in the ear. So tinnitus, hearing loss, and ear related problem. That's only question that you need to add if only dizziness is the case. Otherwise, pretty much same. And in your differential diagnosis, you will just add those conditions. But today we are not going to do the dizziness cluster, so don't combine both of these cluster all together. But dizziness and because postural hypertension comes with dizziness. That's why we kept it in here. Okay, but postural hypertension case also comes to you with a like fall. So it can be anything. It can come with fall, it can come with dizziness. But if it's a dizziness case only, we will ask all the DD as we ask in the syncope, but we just need to add the peripheral causes, which is the ear related causes. Like anything, acoustic neuroma, Meniere's disease, then ear infection, any hearing loss like noise induced hearing loss, presbyocusis, anything of peripheral related causes can cause dizziness also, but that will be most of the time in the AMC. Peripheral causes never ever came up, so don't bother with that much. Okay, let's move on to this vasovagal syncope. 18-year-old girl fainted during marathon. What are the positive points in the history? So girl fainted during running. It was a hot sunny day. And this is also important addendum here. So patient skipped breakfast in the morning and now the BSL is 3.6. Now you have got two cages in one station, which means this patient had a fall. One is vasovagal syncope because it was a hot sunny day. Patient was running marathon. Obviously, that's a vasovagal. And with that, also she skipped breakfast. And now the BSL is less than 4, which means hypoglycemia. So that's also the cause of the syncope that she had. Otherwise, physical examination totally fine. All other questions will be normal. Just this is the positive findings. History will be same like before. Explain that, well, the temporary loss of consciousness that your daughter experienced, we call it syncope. There are many reasons which can cause it, but in your child case, I'm thinking most likely two possibilities. One is called vasovagal syncope. Now, in this condition, in response to certain triggers, especially overexerting in hot sunny weather, can stimulate a nerve in the body, and that can cause pooling of blood in the legs. You can draw the picture also, which results in decreased return of blood towards the heart. And then if heart is not getting enough blood, it is unable to give enough blood to the brain, and that leads to temporary loss of consciousness she had during running the marathon because the brain was lacking of oxygen and blood. Are you with me so far? Yes, doctor. Don't worry, it's a very common cause of fainting and there is nothing to worry about. Another condition that can precipitate this attack is called hypoglycemia or low blood sugar. As your child is, as your daughter skipped the breakfast in the morning, on the top of that, she had to run the marathon, and that can lead to the low blood sugar she is having. Also, we have measured the blood sugar, which is below normal. Don't worry, it should be fine. We will give her something sugary to drink, and the blood sugar should come up. Apart from these two causes, there are also other causes of loss of consciousness. Then you just give all the differential diagnosis and finish this case. For vasovagal syncope, nothing needs to be done. Just you can wait. If the patient comes to the ED, you can observe the patient for 4 hours and everything is, do some investigation, just some basic blood tests, and then the patient can go home. Clear, everyone? Any questions so far? Now, patient doesn't need to be diabetic to be hypoglycemic. Okay, Dr. Samrin. So it's not always like patient needs to be diabetic to be hypoglycemic. If you don't like, if you're skipping your breakfast, or if, and then on the top of that you are running a marathon, probably your blood sugar will be low, even if you're not diabetic. Okay, so it's not necessarily every patient who is hypoglycemic needs to be diabetic. Yes, you will get the recording of the today's class. It will be uploaded, and it's live in the Facebook. So obviously you will it will be in the Facebook group also. But no, not the slides. Slides are only given to our course students, and it's uploaded in the software. Hypoglycemia not necessarily causes vasovagal syncope. Hypoglycemia is a separate cause of syncope. But both of these together can precipitate a syncope. Like patient is running in a hot weather, and that causes trigger of the vagal nerve stimulation. Vagal nerve stimulation will cause peripheral pooling of blood. It doesn't depend on if you are hypoglycemic or not. But on the top of it, you are hypoglycemic, that will make things a lot worse. Clear, everyone? No question? So always in these cases, make sure you are ready to give more than one diagnosis. Sometimes this girl can have underlying pallor. If you ask in the physical examination, pickled, and you ask pallor, examiner will give you pallor positive. Then, then you need to think about why this girl is having pallor. An 18-year-old having pallor most likely is related to period. Maybe she is having menorrhagia. So you have to ask it in the question that, well, when is your last menstrual period? How is your period? Are you having excessive bleeding during your period? And you will find it positive. So then, so see that the cases differs in many ways. We can add something to make the case a little different. So always you have to be open-minded. The next case is recurrent fall case, also very important for the exam. Now, recurrent fall is not necessarily is a syncope case. It's a fall. That means patient is falling, not necessarily loosening of consciousness. It's just like having frequent fall. Okay, it's not total syncope, but as it's related to syncope, we kept it as a cluster. Questions are pretty similar. What are the causes of recurrent fall? Most important cause is polypharmacy, multiple medication, postural hypertension, which can be related to medication, bleeding, diarrhea, vomiting, or any fever or infection. Vasovagal syncope. Now we have CNS cause, CVS cause, like previously. Endocrine, which is hypoglycemia, can cause it. Now, for the recurrent fall case, diabetes is a very important thing you should remember, because not only hypoglycemia, but also diabetic patient can have retinopathy, having lack of vision results in recurrent fall, can have peripheral neuropathy, so patient have numbness, loss of sensation in their leg. So they don't actually understand where they are stepping, and they can fall frequently. So that is neuropathy. So all these are related to diabetes in a frequent fall patient. So we have to be very vigilant in these cases. Electrolyte abnormality can cause it. And then we have anemia. These are the main causes. Now, if you see, all these causes were in our syncope cluster also, right? So same thing, but in here, we just need to add these three things. One is home situation. So home situation means if the patient lives alone, no support, elderly, has a frequent chance of falling. On the top of that, if there is lack of adequate lighting in the house, lack of railings in the stairs, or if the patient is having stairs in their home, if the patient has carpet which is slippery. So we need to find out the home situation, that what exactly causing this frequent fall. Then vision and hearing problem. If a patient has vision problem, hearing problem, that also leads to recurrent fall. Joint problem. If patient has underlying osteoarthritis, patient will have difficulty walking and they can fall. So these are the important thing you will add to our syncope cluster in recurrent fall case. But for your AMC, most important findings is diabetes, polypharmacy, postural hypotension, and this underlying home situation joint problem that can be associated with the other causes. So history will be pretty much same in here. So again, in here, your main history will be fall. So ask about, so how many episodes of fall so far? Can you please describe me what exactly were you doing in each of these fall? Okay. Can you describe what happened before you fall, during your fall, after the fall? That means pre-syncope, syncope, and post-syncope. Same question you will ask here. Then ask the differential. So all the CVS, CNS, Pushual, anemia, all these causes. Same we discussed already. Then past medical history, that's important. So how about your general health? Any history of diabetes, stroke, high blood pressure, any heart condition? Patient can give you, yes, doctor, I'm having a long-standing diabetes. Well, so how long it is? Is it well controlled? Are you on any medication for your diabetes, and what medications are you taking? Any problem with your vision? Any numbness, tingling sensation in your legs? Are you regular with your specialist? Do you know what is your last HbA1c? HbA1c helps us to find out if the diabetes is well controlled or not. Clear? So if positive diabetes history is there, you have to ask all these questions to find out what's going on. That's very important, because diabetic retinopathy, diabetic peripheral neuropathy, all can lead to frequent fall. And then after that, SADMA, medication history, smoking, alcohol history, very important. Home situation. So who do you live with at your home? Do you have enough support? Any loose carpet? Any problem with lighting? Do you have stairs at your home? If yes, then do you have railings in your stairs? These are important questions. Any joint pain? Any problem with walking or keeping balance? So support is very important. So who do you live with, as we already asked, and do you have enough support? In the PEFE, general appearance, vitals, BMI. Now, in this case, for especially diabetes case, you need to ask eye examination finding. So I would like to check the eye, checking for visual acuity, visual field, and fundoscopy. When you say fundoscopy, sometimes examiner can say, well, there is diabetic retinopathy features in your fundoscopy. So then you get your one cause of frequent fall. On the top of that, you have found diabetes also. Then just finish with CVS, CNS, musculoskeletal system. Office test is BSL and urine dipstick. Now remember, for CNS examination, in here you have to specifically ask about diabetic peripheral neuropathy features. So you will say, doctor, I would like to do full upper limb and lower limb neurology with cranial nerve, especially looking for any sign of peripheral neuropathy related to diabetes. So peripheral neuropathy signs are very important, which means peripheral neuropathy usually gives you glob and stalking kind of loss of sensation in the extremities. So that's your CNS examination finding. This patient can have osteoarthritis or knee pain. So you need to do the musculoskeletal system exam. Say that I would like to do the musculoskeletal system for any visible swelling, redness, tenderness, or restricted movement of any of the joint. So redness, swelling, any tenderness, and restricted movement. Lastly, do the office test, BSL urine dipstick. Now, positive points in this case could be patient had a 3 episodes of fall, diabetic for the last 10 years, numbness, tingling positive, vision problem positive. Patient has knee joint pain for a long time, history of a stroke previously, taking physiotherapy now. In the PEFE fundoscopy retinopathy feature, CNS peripheral neuropathy feature, and BSL 16, which means it's not well controlled. Okay, so that's your positive finding you might can get here. How you are explaining this? So most likely the cause of your recurrent fall is uncontrolled blood sugar, which is now causing complication like peripheral neuropathy and diabetic retinopathy. In peripheral neuropathy, the nerves that supply your extremities get affected and that cause the numbness and tingling. And that's why sometimes you may not even feel where you have been stepping. So you can have recurrent fall. Also, we have found some eye changes related to diabetes, and that's affecting your vision. And that also can lead to the frequent fall you are having. Other than this, you are also having knee joint pain and knee joint changes, which can lead to recurrent fall. After you have given these causes, then give all other differentials. So it could be due to other causes also, then you give the other differential diagnosis. Clear, guys? So that's your recurrent fall case. Remember, recurrent fall, sometimes you might not even get any diabetic finding. At that time, think about postural hypotension due to polypharmacy. That also causes recurrent fall. Any question? So that actually finish our syncope cluster. Now see that just doing a single cluster, we have finished 5 or 6 cases, right? So if you can just remember one history format and one PEFE format, then all cases are pretty similar. And most of the time they don't ask you management. So just you need to remember how you are explaining the things. It's pretty easy if you're doing this way, right? Any question? Dr. Rubel, which scenario you are asking about? Sorry, I haven't seen your message earlier. So in this scenario, do we need to take consent from patient? For which scenario, Dr. Rubel? Now, ECG is not very important in recurrent fall unless if you get some history of heart related condition. So if you get like this patient is having uh, chest pain, shortness of breath, or patient had hypertension, ischemic heart disease before, then ECG is good. Now, any elderly patient, when they come to us, we usually do a ECG. So if you do ECG, that doesn't make you less, it's actually good doing ECG in every elderly patient. Yeah, Dr. Cookie. So recurrent fall can sometimes, no, I haven't said that. Dr. Kuke, I meant that diabetic patient not necessarily should have recurrent fall unless they have complications. What are the diabetic complications related to fall? One, if they cause postural hypertension due to autonomic neuropathy. Second, if the patient has peripheral neuropathy or diabetic retinopathy. These three complications can cause fall or syncope in a diabetic patient. But if diabetes is well controlled, no complication can happen. Patient may not have any fall. Yep, epilepsy can be a cause. That's why we ask during syncope, did you bite your tongue? Did you wet your pants and any jerky movements? Epilepsy can be a cause. You cannot consider postural hypotension unless you find it in your examination. So if it is postural hypertension, you have to ask it from the examiner, doctor, I would like to check the blood pressure in sitting and standing position. And then if there is more than 20 millimeter mercury change in systolic blood pressure with a standing and sitting position, then you call it postural hypertension. Like patient on sitting position, systolic blood pressure was 120. When they stand up, it came up as 100. So there is 20 millimeter difference. Then it's a postural hypertension. So I guess we'll finish here tonight because the palpitation cluster, it's good idea to start as a new in the next session. Otherwise, we have to start it again in the next session. So two cluster is still is there. One is palpitation cluster, and we have our chest pain cluster. Okay. Normally, in the initial few classes, we usually take some time because it's a all new for you. I usually give you more time to discuss these cases so that you guys can understand. And once we finish five, 5, 10 classes, if I move faster, it will be easier for you to take. But at the moment, I'm not moving so fast. I'm moving slowly so that you guys can understand my how I take classes, because it's always adaptation with the teacher, that how the how you make adaptation, it makes you feel better with ongoing lessons. Okay, so always I start very slowly and then I move faster. Okay, so tonight let's just finish with the syncope, and then we will, if needed, we will take more classes for cardiology. That's okay, because at the end you guys will be more oriented with my approach, and then I can go faster. Ah, Dr. Samrin, you are after MCQ. This is a clinical course, Dr. Samrin. So MCQ is also starting same time. So the the first lesson of MCQ is tomorrow. Are you in our MCQ group in the Facebook? Oh, not yet. So you should be in our MCQ group, not in the clinical group. It's good you are here, but I don't think it's still the time to go through these clinical cases. So send me a message in my messenger, okay? Or however you, so if you are in our Facebook group, so you might be able to uh, send me a message. Send a message, and I will add you to the MCQ group. Okay. Okay, I'll have a look. Or just send it now so that I can see again. Or you can write it in your Facebook as a first aid AMC MCQ, and then you should be able to get the group. Just send an add request. I will accept you. Yeah, MCQ classes are also free for 2 weeks. Are you guys are all from MCQ? How come? We have given it's a clinical session. Okay. Um, Anyone else from clinical having any difficulty? So you guys have got it already. So the next session will be on 1st of November, and we'll start with the palpitation cluster. Yes, Dr. Farah, what's your question? And any of you are from MCQ, make sure you get into our MCQ course, and the MCQ, the 2 weeks free sessions are starting from tomorrow. And also we have uploaded a lot of times the like the schedule also. I don't know how this mixed up, but it's okay. It will be same time tomorrow again. So make sure you send me a message or email, anything, so that we can help you. So Dr. Kuki, we take our fixed classes are 2 days per week, and it's most of the time 2.5 to 3 hour session. But most of the weeks we also try to take another class, usually for role play session. That's extra class is mainly for role play, that doesn't have any exact schedule. When we finish a cluster, then we give a date for those role play session. But we do role play of most of these clusters. Same time, Dr. Wafi. Yeah. How will be the physical examination conducted? Now, in the main exam, it's not totally sure how they are going to make the physical examination. As far as they have revealed, it's 1 8-minute station and 2 4-minute 4-minute short station. As I don't know, like if you have seen how we have taken the physical examination, most likely that will be the case. Most likely the short stations will be like within 8 minutes, there will be two short stations. They will just ask, like you need to ask some physical examination finding, and the examiner or the invigilator who will be with you, they will give you the findings, and you need to interpret those findings and get a diagnosis. That's your short physical examination. The long one, again, you will you need to do same thing, but there will be no patient. You will just ask the patient to do these things, like you just need to command the patient to do this. And when you will command appropriately, if there is any positive finding, the invigilator will give it to you. Most likely this is the only way they can take the physical examination, that 8 minute station. Okay, so obviously they will show or they will give us some video that how it's going to happen before the exam starts. So if there is any change, we'll be able to give you some help in that time. But at this moment, still we will finish all the physical examinations that we are supposed to do, so that if anything comes, we are able to at least say something in the exam. No, it's not difficult. Remember, when you will be doing physical examination on a patient, it's more difficult than just saying it to the patient. because you have to perform it, you have to find out the positive findings, and you have to give running commentary. So it's more difficult doing it on a patient rather than just asking the patient to do something and examiner is giving you the findings. It's easier. It's because you guys are not oriented with this new format. That's why you guys are feeling a little anxiety, but it's a lot easier than doing a face to face. All right, then. Thank you so much for joining today's session. I hope this helps you a lot. We'll see you soon in the next session. Have a good night.